Hello and welcome to Devon and Cornwall's Aesthetics Academy. My name's Lisa and I'm going to be taking you through the botulinum toxin training today. So my name's Lisa and as I've aforementioned, I'm going to be doing the botulinum toxin training today. So just a little bit about myself. So I'm an independent nurse prescriber who works in Exmouth and runs a clinic called Exmouth Facial Aesthetics. I've been nursing for around 27 years with my main background being trauma, orthopaedics. I also currently still work within emergency medicine alongside running Exmouth Facial Aesthetics. I teach in my normal NHS job as well as this job here. I regularly teach paramedics, nurses, doctors within our local minor injuries unit. So I started my foundation aesthetic training with Professor Bob Carner back in 2014. Bob Carner is an industry master within the world of aesthetics. Following on from this, I then trained with some of the more common companies such as MERS, Galderma and Vivacy, all reputable companies that you will find out more about along your journey within aesthetics. So my passion lies with wrinkle relaxing injections, and that's why I'm here to teach you the botulinum toxin part of the foundation training today. And then also part of the team is Astra. Astra is a registered nurse prescriber also, and she runs a busy clinic in Devon called A Little Enhancement. Her nursing background includes cardiothoracic surgery, plastics and maxillofacial, but most recently tissue viability. She now practices as a full-time aesthetic nurse and sits on the specialist panel as a tissue viability nurse for a complications group called Complications in Medical Aesthetics Collaborative, also known as CMAC. She is also a panel nurse representing the South West for the International College of Aesthetic Nurses. Astra has been selected by Allergan Medical Institution in 2017 to undergo expert specialist training in the administration of facial aesthetics and injectables. She has recently completed a 4-year expert programme taught by world-renowned medical aesthetic doctors. And lastly, meet Heather. Heather is our training coordinator at Devon and Cornwall Aesthetics Academy. She's in charge of the day-to-day running of all our courses. She organises all the delegates as well as the models to ensure the day runs smoothly. Heather has extensive background knowledge in managerial roles, including HR management within the NHS. Heather has worked within aesthetics for many years and is also Astra's clinic manager at A Little Enhancement. So the objectives of the day: we need to understand the term facial aesthetics. We also need to look at the pharmacology of the botulinum toxin and its effects on the face. We need to understand a little bit about facial anatomy and also the laws around the aesthetic industry. We will hope to describe the ageing process and how this will affect an individual treatment plan, also carry out detailed consultations with facial mapping and safe administration of the botulinum toxin injections, and also potentially identify and deal with any complications. So what is facial aesthetics? Facial aesthetics is the term used to describe the range of non-surgical treatments. This can include the softening of lines and wrinkles, softening of expressional lines, defining facial features and contours, and also altering facial proportions, i.e. volumizing and harmonization. So now we understand a little bit more about facial aesthetics. How can we achieve these outcomes? These can be achieved using a number of treatments that we can offer in aesthetics. We can use dermal fillers, we can use toxin, we can use microneedling, chemical peels, platelet-rich plasma or plasma pen and fibroblast treatment, and also radiofrequency treatment. All of these things restore and enhance facial aesthetics. So in order to carry out these treatments, we need to think about what causes these problems within our patients. And one of the things that people will come to us is the ageing process. Now, this obviously can't be changed. Everybody's going to age. So we need to understand about the different processes that our body will go through during these changes. So first of all, we can look at the skeletal changes to the face. We have the largening of the orbital rim, and it also changes shape. We get bony reabsorption around the oral region, reduction of angles between the nose and the upper lip. The length and the height of the lower jaw decreases and the gonial angle widens. On top of the skeletal changes, we then begin to look at fat pads. With a youthful face, we have tight and plump fat pad. As we age, these fat pads will start to shrink in size, decrease in volume, and also change position. Muscle. Lean body muscle decreases with age. We also get a loss of muscle tissue, known as atrophy. The muscles also become less toned and are less able to contract due to changes in the muscle tissue. Muscle mass and function can change from as early as 30s. On top of the muscle, we then have skin. You may be surprised to find out from around the age of about 25 where the first signs of aging start to become apparent. First of all, you will see loss of elasticity, with a loss or reduction in the connective tissue, also a loss of hyaluronic acid and a decrease in collagen. Finally, the reduction in the size and number of lipid store cells in the adipose layer reduce. All of these things add to the skin looking more aged. Now look a bit more closely at botulinum toxin, or Botox for short. Botulinum toxin is a neurotoxic protein produced by the bacterium Clostridium botulinum and its related species. So how does it work? Botulinum toxin binds specifically to the nerves that use acetylcholine. This then prevents the release of the neutron transmitter acetylcholine from the axon endings. This occurs at the neuromuscular junction and will then cause flaccid paralysis of the muscle. This process is then slowly reversed as the toxin loses activities and the snare proteins are slowly regenerated by the affected cell, known as the sprouting method. Botulinum toxin lasts approximately 12 to 16 weeks. Each person is individual and there can be other factors that can reduce the longevity of the toxin. So this slide here just shows the botulinum toxin activity. So if you look at week 1, you can see we have our full range of natural muscle activity. When we inject the toxin, it can take up to 2 weeks to start working. Within that 2 weeks, you will then start to notice some induced muscle deactivation. And that muscle deactivation will continue over a number of weeks until it peaks at around about 6 weeks. So around about 6 weeks, there should be no muscle activity. Round about week 7, the sprouting method starts to occur, and gradually over a process of time, it reverses the process as shown in the diagram. So round about week 14 to 16, you can see that full natural muscle activity is regained. This is very important when explaining to your patients about how long the Botox will last. Quite often people complain that their Botox doesn't last because they have an understanding incorrectly that it should last for the full 16 weeks with no movement. This is not the case, and this diagram is useful to show your patients to educate them. There are a number of different brands with botulinum toxin. They're all toxin type A, but are just made by several different companies. So we have Botox, which we'll be using today. We have Bocuture, and we also have Azelur. The dosage between each of these different brands is very different. So the dosage that we're going to be talking about today is specific to Botox doses only. Now, toxin can be used for many medical reasons: migraine, sweating, muscle spasticity, alongside the cosmetic side. It was first founded cosmetically by Richard Clark, a plastic surgeon, in 1989 by accident when treating migraines. But it wasn't actually until 2002, following a clinical trial, that the FDA finally approved Botox for cosmetic indications. Botox can be reconstituted with normal saline, bacteriostatic saline, or Torbac. There are 2 different size bottles that you can purchase depending on the amount of areas which you need to treat. It's very important that you follow this guideline to show how much of the diluent you need to mix with each bottle to ensure that you get your units correct. So just a little bit about aesthetics and the law. You might be surprised to hear that there is actually no law that is stated about who can and cannot inject Botox. However, as medical professionals, we all have to adhere by our professional code of conduct, i.e. the GDCE, GMC or the NMC. All of the reputable insurers, i.e. Cosmetic Insure, Hamilton Fraser, will not insure you to prescribe remotely or for anyone other than a medical professional who carries out Botox treatments. There are an increasing number of beauty therapists and other non-medical people starting to carry out aesthetic treatments. This is not against the law. However, it is against our code of conduct to participate in facilitating them to train and to treat people. All of your clients need to have a face-to-face consultation with a prescriber if you're not a prescriber yourself. It's also good practice to give a 24-hour cooling off period to allow them to change their mind if they've actually gone home, had a little think about it and decide that they don't want to go ahead. Nurses are not allowed to hold stock of this drug, however doctors are able to do so, or if you work with a medical director within your company, you can also prescribe from the stock if you are a prescriber. Advertising Botox is illegal for two reasons really. One of them is due to trade of copyright. Botox is actually copyrighted and you cannot advertise it. It's also illegal to advertise a prescription-only medicine. This is the MHRA guidelines. And this unfortunately includes before and after photos. You may also not offer any discounts on any prescription medicines. The reason for this is that it can be seen to be enticement of treatment of a medical treatment. So as I've already mentioned, there are no laws around aesthetics and who can and who cannot inject the public. An independent review by Bruce Keough back in 2018 recommended that all practitioners should be properly qualified to carry out the procedures they offer. He also just suggested that an ombudsman should be instated to oversee all those providing treatments and to help all those that have received poor treatments. However, since this, back in 2018, the government has initially failed to respond to these recommendations. Things very recently, though, have just started to move on. As part of the Health and Care Act 2022, the government has now given the Secretary of State for Health and Social Care the power to introduce a licensing scheme for non-surgical cosmetic procedures. This is very much in its infancy at the moment, though, and has yet to go to public and stakeholder consultation. The JCCP, Joint Council for Cosmetic Practitioners, is a leading group within this. So now let's look a bit more closely at the consultation process. This is your chance to build a relationship with your clients which will develop over time and help you with the retention of your clients. Firstly, you need to just ensure you take your time. Make sure you always introduce yourself and your qualifications. This is important. You need to make your patient feel safe and that you are well qualified. And then you can start to explain about the treatments you offer. So what sort of things should you ask for in a consultation? Things to ask: how they found out about you. Is there a recommendation from others? What brings them to your clinic? What would you like to change, improve? I normally give the patient a mirror and ask them to point out specific points in which they require change or improvement. Be very wary of patients asking, no, what would you change? What do you think I need? There are a number of patients that seek treatments that will have body dysmorphia and unrealistic expectations. It's very important that we only discuss patients' problems with what they have pointed out for us so that we don't end up giving the patient a complex. Once we know what the client wants, we then need to manage client expectations. Always point out any existing asymmetry. Always point out any existing asymmetry, as the patient will often not have studied their face very closely until the treatment, and then when they do look more closely following the treatment, they may think that you have caused the asymmetry with the toxin treatment. You also need to explain the limitations of treatment. Many people don't understand Botox and think that actually it's just going to iron out some lines. You need to explain to them about the muscle movement that causes the lines if there are a lot of treatments required. The more they understand about the limitations of treatment, the less likely you are to have an unhappy patient. I tend to offer a treatment plan extending over the year if there are a lot of treatment requires and it suits the patient's budget to do it gradually. But finally, don't be afraid to say no. If you get a gut instinct not to treat a patient, if the expectations are too much and you don't think that you can manage them, it's far better to say no, and then you won't have an unhappy patient. My motto is under promise and over deliver. So once you've talked about managing the client expectations and you're both happy to proceed, you then need to see whether they're medically fit. So a medical assessment is carried out just as it would be within your normal job. So we need to look at medical, surgical and dental conditions. Dental conditions are very important within facial aesthetics because of the close proximity of where we're working and the risk of infection. You need to check any relevant allergies, not only to the toxin but to the skin preparation, latex, etc., or anything else that is likely to be used during the treatment. medication. You need to look at the patient's medication. There are a few medications that do not interact well with Botox and can exacerbate the effects of Botox. So you need to be aware of these when you're doing your medical assessment. It's important to explore any dermatological conditions. Any condition which is actively flaring up on the face, causing redness, swelling, spots, you would avoid injecting. You can always postpone the patient and bring them back when the condition has settled. We also need to consider any previous aesthetic treatments, both toxins, chemical peels, radiofrequency, fillers. Any recent treatment should be left at least 2 weeks before we treat with another treatment. It's not that they will necessarily interact with each other, but if there is a flare-up or any side effect from one treatment, then it may be too close to the other treatment to work out which one it's going to be coming from. We also want to know with previous treatments whether they've been happy, whether they've had any side effects, particularly for things like Botox. Sometimes if people have too much Botox injected into the forehead, for example, it can give you heavy eyebrows. So if we know this before we treat a patient, even if we haven't treated them and they tell us this, we can then do a lower dose to start with and then obviously inject some more when they come back in 2 weeks for a 2-week review when all of the Botox has fully worked, because as we've already said, it can sometimes take up to 2 weeks to work, so you would never aim to retreat or top up anybody within that 2 weeks. And then finally, before we even think about going ahead, we need to gain informed and valid consent and make sure this is documented. Now, there are a number of ways in which you can document this. Most of the companies will actually give you their stationery where they have pre-filled consent forms and medical history forms. There are also a number of electronic versions which we can talk more about on the day when you come in for your practical day. During the consultation, we also need to talk about possible side effects of Botox, and this will allow them to make an informed decision as to whether they would like to go ahead with the treatment. So some of the possible side effects that are listed are unintended paralysis of facial muscles. So the Botox will spread roughly about 1.5 centimetres. So when we inject very slowly and very carefully with small doses, so we allow the toxin to stay where we inject it. If it's injected too quickly or in the wrong area, it can cause unintended paralysis of facial muscles. Sometimes people report headaches. Sometimes people report flu-like symptoms. You can also get dry eye. Allergic reactions are relatively uncommon. Skin infections. Please make sure that your patients are cleaned properly before you inject, and also advise them not to wear any makeup after the treatment. Bruising is often discussed as a side effect, but this is not actually a side effect. This is more due to the mode of administration. There are lots of vessels around the eyes and sometimes bruising does occur. So I always just explain to my patients that it's unlikely, but it may occur. Never inject anybody close to any special events for this reason. So facial anatomy. This is where we need to really understand the facial anatomy before we start to inject in order to prevent any side effects from occurring and also to get the best treatment for the patient. As you can see, there's quite a lot of muscles there within the face. Thankfully, for the treatments that we're doing, we're only using Botox in the upper face, so we only need to concentrate on a small group of muscles. So the first muscle we need to look at is the frontalis muscle. And this muscle origins at the bridge of the nose and inserts at the galea aponeurotica over the forehead. The importance of this is that the origin of the muscle is always the strongest point. So when we inject, we want to inject safely over this muscle. This is also known as the forehead. The action of the frontalis muscle raises eyebrows and wrinkles the forehead. So when you elevate your eyebrows, you'll find that you will get horizontal lines running across your forehead. This is the frontalis muscle. The next group of muscles within the forehead are called the corrugators and the procerus muscle. The corrugator is a paired muscle, one each side of the eyebrow, and the procerus is a muscle within the centre. These are collectively known as the glabella. The action of this muscle is to draw the medial angle of the eyebrow down, giving the expressions of frowning, often known as creating the 11s lines. And lastly, the muscle that we're going to be looking at and treating is the orbicularis oculi. This is the muscle that runs around the eye. So this is a circular muscle. Its action is a brow depressor, especially laterally. It also contributes to the closing of the eyelids and causing wrinkling of the skin to the lateral eye, also known as crow's feet. Patient assessment. So when we look at the patient, we're looking for two things. Initially, we're looking to find any static lines. So static lines are lines that are there within the skin, but at rest of the muscle. So no facial expression, just neutral. As you can see from this patient, he's just started to get a couple of static lines at rest. It's very difficult quite often to treat static lines with Botox. If they've already got some static lines and they're quite deep, they are not going to go with one treatment of Botox. What you will find is that they will get better if the patient continues to have Botox over a period of time, but it's really important to manage expectations and point these out to the patient and actually let them know that it may not get rid of them with one treatment. What we can work on is the dynamic lines. So the dynamic lines are lines that occur with muscle movement. The lines in the skin form because of the movement of the muscle underlying that's attached to the skin. The botulinum toxin relaxes the muscle, so will relax all these lines that you can see on this diagram here. So let's look at the frowning lines. Glabellar frown lines can be treated by targeting the procerus in the middle and also the corrugators above each eyebrow. The forehead lines will be treated by targeting the frontalis muscle. The crow's feet will be treated by targeting the orbicularis oculi muscle. When marking up your patients, it's important to make sure that you mark them up in animation. So that's on muscle movement, not on relaxed lines. So there are a number of factors, as I've explained previously, that can influence the toxin dosing. The sex, generally speaking, men need more toxin than ladies. Ethnicity, skin type, the size of the muscle, the extent of the wrinkles, and also previous responses to Botox treatment can influence what dose we are going to decide to use. So let's break that down a bit more clearly. Men have increased cranial size, they also have a unique cranial shape, and they have a greater skeletal muscle mass. They also have a higher density of facial blood vessels and more severe facial rhytides. The eyebrows sit under the orbital rim and possess a straighter shape. Men very rarely have arched eyebrows. They tend to be more flat as opposed to ladies, which are more arched. Ethnicity. So different ethnicities have thicker dermis, i.e. Afro-Caribbeans will have thicker skin. Typically, the darker pigmented skin types can have a thicker dermis. Patients with a thicker skin are more resistant to actually getting the wrinkles that the toxin is designed to treat, but once they do get the wrinkles, they often require larger amounts of toxin to get a good effective treatment. Skin type is important. Wrinkles caused by sun damage and gravity will not respond to Botox. Botox only treats the lines that are caused by muscle movement. The size of the muscle mass, so typically the bigger the muscle, the more dose of toxin will be required, particularly in men. Men will often need double the dose in the forehead of a lady. And also the extent of the wrinkles. More wrinkles will require a larger dose of toxin. Be very aware of chasing lines. It's always better to do a general standard dose of Botox and then add more at the 2-week review. You need to remember that the underlying anatomy is responsible for holding up your eyebrows and also your eyelids. So if you treat too aggressively, you can cause problems with dropped eyebrows and dropped eyelids, which we will go into a bit further later. And then we also just need to discuss any previous response to Botox treatment, particularly if it's a patient of yours where you've treated them initially and they came back for a review in 2 weeks and they still had a little bit of movement, you can then top up that patient, but then next time you can increase that initial top up within the initial dose to make sure that you get the best result straight away. So now let's look a bit more closely about where we're going to mark up before we inject. So let's look at the glabella. The glabella treatment is 5 injections. The first one is in the procerus muscle, as shown in this diagram. It's generally 1 centimetre above the nasal fold, which sits just between the eyebrows. The dose for this is 4 Botox units per injection site. 4 Botox units is the equivalent of 0.1 ml when it's been reconstituted by the manufacturer's guidelines. The depth of this injection into the procerus muscle is deep, approximately 6 to 8 millimetres, with an angle of 90 degrees. Then we can move on to the corrugator muscles. So as you can see in this diagram here, the markings are applied whilst the patient is frowning. The first one is generally in line with the medial canthus and in the bulk of the muscle. So you can see the centre of the muscle where that first injection is. The second injection is 1 centimetre up from the first injection and not passing the mid-pupillary line. The mid-pupillary line is an important marker for reducing the risk of any serious complications. If you inject past the mid-pupillary line or you inject too deep in the mid-pupillary line, you can give somebody an eyelid ptosis. The dose of these are the same as the procerus, so it's 4 Botox units per injection site. The first injection is deep, the same as the procerus, and the second injection is very shallow. In the second injection, we're just going to be popping the needle just under the skin to allow the Botox to diffuse down. The reason for this is that the tail of the corrugator of the second injection site is very thin. And if you go through the tail of the corrugator into the levator muscle underneath, then you will cause an eyelid ptosis. Then we can move on to the frontalis injections. The frontalis injections are the ones that target the forehead lines, 2 to 3 Botox units. As you can see, there's 5 injection points. They're generally spaced in an M-shaped formation for a lady. The M-shaped formation will mimic the lady's eyebrows. For men, I tend to go straight across because men have flat eyebrows as opposed to arched eyebrows. However, if they would like arched eyebrows, then you can use the lady formation of the M. The injections are lower dose than previous, so we're looking at 2 Botox units per injection, and they're also very superficial. The anti-spock on the lateral edge of the eyebrow is an important injection to prevent what we would call a spock brow. A spock brow will be discussed further in the presentation. The orbicularis oculi, or commonly known as crow's feet. The orbicularis oculi muscle is a series of 3 injections around the lateral aspect of the eye. The first injection is at the tail of the eyebrow, or the alar outer canthus line. So that's from your nose to the edge of the eyebrow. This is injection point 1. Injection point 2 is the intercanthi line, so that is just lateral to the edge of the eye. The third injection is 1 centimetre from the second injection, following the muscle round in a circular action as the muscle itself forms. The injections dose around the eye can be between 2 to 4 Botox units per injection site. The depth of these are very superficial and very flat. You must make sure when injecting around the eye, you always inject away from the eye and place a finger around the orbit to prevent any diffusion of the Botox into the eye area. They're very superficial injections. So once you've done the treatments, we then need to get the patient back for a review. The reviews are really important. The reviews are a good example of your work to the patient and also good for them to see the befores and afters. Befores and afters of Botox treatments absolutely look amazing, and they really do sell the treatment and also give you a good record of your medical treatment. Medical records need to be kept for 7 years and the photos need to be kept for 3 years. So you will need to find a good device with rather a lot of storage and obviously security protected to allow this to happen. There are a number of apps that you can use to put your befores and afters together, which we will show you more when you come on your practical day. But I just wanted to show you just a couple of photos of my own, which of treatments, so you know what to expect. So this lady here is shown in neutral expression. So the picture before is obviously the one on top and the one below. So remember, neutral is expression with no raising eyebrows, no expression. So you can see actually from just one treatment, she's had a very good result from the Botox treatment with her static lines. When we look at the frowning lines, this is when the treatment becomes into its own. You can see from the top that she can frown and has got quite an angry looking face, and on the lower picture she's now unable to frown and therefore doesn't have the lines and wrinkles that she wanted to get rid of. And then finally, the other one we need to look at when comparing is the elevation of the eyebrows. The frontalis must never ever be treated without the glabella, as this will definitely drop the eyebrows. So as you can see, the top, the elevation of the eyebrows creates quite deep wrinkles. With the picture afterwards below, there is no wrinkles when she elevates. Now, we need to be careful when we're injecting the frontalis. So this is a frontalis treatment. There are some people that are not suitable for a frontalis treatment. If they have a heavy brow or they have hooded eyelids already before toxin, please don't inject them with toxin, because it can make it worse. Here's another one. So you can, on this, you can see my actual markings of where I mark the patient up. So this is a neutral expression, elevating the eyebrows. So from this one, you can see she's still got 2 lines that are forming on the lateral edges of her forehead. That is the best result this lady's going to get. If I were to try and top up those lines, you will notice from previous photos she had quite hooded eyelids. So if I try to top that up to stop that happening, she would be at risk of eyebrow drop. It's useful to explain this to your patients so that when they come back, if you need to do a top up, you explain the risks again and explain that you could top it up, but there could be a risk of an eyebrow drop. Then actually they do tend to say they would rather just leave it, and I seem to be quite happy with those results. And there's another one again in frowning. And then lastly, smiling. That's one side, and then that's the other side. So hopefully, following on from this on your practical day, you're all going to get some great results like this. Unfortunately, as with everything, sometimes there can be complications. So complications that can occur from Botox treatments. Well, the first one, and probably the most serious, second to an anaphylaxis reaction, which is very rare, is an eyelid ptosis. So this happens when toxin has been injected too deeply into the second corrugator point. The toxin seeps through the corrugator to the underlying levator palpebrae superioris muscle, and this is the one that controls the opening of the eye. How to treat this is actually quite difficult. There is some anecdotal evidence that if you use an electric toothbrush to try and stimulate the muscle, then actually it will help to lessen the ptosis. This is, however, just anecdotal. You can, however, prescribe or get your prescriber to prescribe 0.5% of iodopine eye drops, as this will stimulate Muller's muscle to help retain the muscle activity again. It's quite important when you're looking at eyelid ptosis to make sure that it is a true eyelid ptosis. People quite often think that an eyebrow drop is actually an eyelid ptosis. So when you're assessing an eyelid ptosis, you need to look at the region of the actual eyelid. Any eyelid ptosis will show by an eyelid that drops over the coloured part of the eye, so over the cornea. If it starts to drop lower, as shown in the picture above, then that's when it's a true eyelid ptosis. Sometimes they can be a bit more subtle, sometimes they can be a bit more severe. If you look at the picture at the bottom, then you can see on the picture that one is literally only showing half of the eye, so this one would be certainly suitable for some eye drops. Brow ptosis, however, is much more common, and this is either caused by injecting too low on the frontalis muscle or too much toxin in the frontalis. Now, If you inject too low on the frontalis, you remove some of the natural ability to hold the eyebrows up. So we leave a 2 centimetre margin above the eyebrows before injecting any injections into the frontalis. This will help prevent that. It can also occur by treating the frontalis muscle alone. As we know, the frontalis is an elevator muscle. If you just treat the frontalis muscle, you lose the ability for that muscle to elevate. If we then think about the glabella, that muscle itself is a depressor muscle. So if that muscle is still active, it then becomes stronger than the frontalis. And it's a bit like a tug of war effect. So you've got inactivity on one end of the tug of war and activity on the other, then it's obvious the one with the activity is going to win. So if the frown lines are depressing down, what will happen is that will get more aggressive. So they will actually pull down even more. So you would never ever treat the frontalis muscle alone. You can only treat it in conjunction with the glabella. So if you did get a brow ptosis, if there is still some glabella movement present, you can treat this by adding a little bit more toxin, because as we know, if the glabella is a depressor muscle, if we put Botox in this, it knocks that muscle to sleep, it can't depress, so it can't pull down. So then you get a little bit of elevation to support the frontalis. You could also try 2 Botox units just below the lateral brow, because this is also a depressor muscle naturally, to try and give a little bit of elevation to the lateral brow edge. But ultimately, more often than not, the best thing is just to let it wear off. You can treat the glabella without treating the frontalis. The reason again is because the muscle action of the glabella is a depressor. So if you just wanted to treat frown lines, if you treat them, then the muscle can't pull down, then the elevator muscle of the forehead lifts this area. It actually gives quite a nice little lift in the mid eyebrow area. A Mephisto or Spock brow. So this is caused by not injecting laterally enough along the frontalis. This is one of the more easier complications to treat. All you need to do is to add a little bit more toxin to the lateral frontalis. When we talk about a little bit more, we are literally talking like 1 Botox unit. That will just relax the outer aspect of the frontalis and drop the eyebrows slightly so that it doesn't give this weird Spock brow. As you can see from the patient in the corner, you sometimes get a little tiny line also above the outer eyebrow. This is what we call a comma. So quite often people have these lines anyway in their forehead, but what will happen is when we treat the whole of the forehead, we relax all the muscle, but because we can't treat very low, you are left with little tiny commas above the outer eyebrows. I often pre-warn patients at consultations that these will occur, and then I often treat them afterwards. So when the patient comes back at 2 weeks, you can just add 1 Botox unit about 1 to 2 centimetres above the main area of the muscle pool. These are just some of the complications that can occur with Botox. We strongly recommend that you join Complications in Medical Aesthetics Collaborative Group, also known as CMAC, who can provide you with the evidence-based guidelines to use in clinic. They have a guideline base for all of the complications that you are likely to come across. This is all available for a small annual fee, and you will also have access to a global team of specialists who can help provide support in the event of a complication. So I hope that's taken you through the theoretical component and you're now a bit more confident in your knowledge when coming to the next practical day. Please be aware that I will be going back over any questions, anything that you have. So if you'd like to jot down any questions, any things that you didn't understand, anything you'd like to discuss in further and bring it with you on the day, that would be great. Thank you. So thank you for listening. I hope you found the theoretical component interesting and you've learnt lots. If you have any questions or anything you'd like to know, please either bring the questions along to the day or you can find me on Devon and Cornwall Aesthetics Academy webpage. My name is Lisa. Thanks again.